So, the Neurosciences Forum meeting we are conducting every month for past 2 years, I think. And usually we combine this program along with the Indian Medical Association, Academy of Medical Specialties of the Coimbatore branch. We often have the one neurosurgeon or neurophysician and the allied specialties also we are trying to bring it into our forum so that our postgraduate students in neuro department, neurosciences, and also our practitioners will be benefited. That's why we have created this program and we are continuously conducting this program often. And today, the main important thing is in this program is I request all of you to please enter your name, the registration number, the email ID, and WhatsApp number in the chat box so that the Zoom recording will show the participants listed, all those things. So I invite all of you to register, please. And another important thing is that at the end of each session, we will be having questions and you need to answer immediately online itself. In the chat box itself, we have to answer. And finally, at the end of both the talks, we will be announcing the winners. And winners will be awarded with prizes. So, we will start the program with the first speaker being Professor Dr. G. Edmond Jonathan. Naveen. Professor Edmond Jonathan is professor and head of the neurosurgery third unit, Christian Medical College, Vellore, and highly accomplished neurosurgeon and academic leader with expertise in advanced spine surgery, skull-based surgery, and minimally invasive neurosurgery. Over a decade of progressive leadership at CMC Vellore with strong contributions in clinical excellence, research and international fellowships, recognized with multiple national awards and global training exposure. Current role, professor and head neurosurgery third unit and Christian Medical College, Vellore, 2025 at present. And he did his education from MBBS from SV Medical College, Tirupati, and MCH Neurosurgery from CMC Vellore, and FRCS Neurosurgery, Royal College of Surgeons, England, 2023. Career progression. He is from the senior house surgeon neurosurgery from 2008. He has reached the level of the professor of neurosurgery CMC Vellore by 2021. At present, he is and super specialty training internationally, advanced spinal endoscopy from South Korea 2023, endoscopic skull-based surgery, University of Pittsburgh, USA 2023, minimally invasive spine surgery, Busan, Korea. The academic and research profile, 50 plus of peer-reviewed publications in international journals, regular faculty and invited speaker at national and international conferences, active researcher in spine, skull base, and neuro-oncology, clinical expertise in minimally invasive spine surgery, endoscopic skull base surgery, complex cranial and spinal disorders, neuro-oncology, and vascular neurosurgery. I now invite Professor Dr. G. Edmond Jonathan to give his lecture.
Thank you, sir, for the kind invitation. And also, I thank IMA President Dr. Kaushal for giving me this opportunity. Special thanks to Dr. Vikram. Without any delay, we will be discussing about today's topic. So today, the topic given and asked to present is on basics of endoscopic spine surgery. Nowadays, it is the current era is to approach minimally invasive for major spine pathologies. So, what is the endoscopic spine surgery and what are the basics and what is the future of spine surgery? Today, we are going to learn in this few minutes that we share the screen on. The outline of the talk is going to be on anatomy of lumbar spine. We're going to talk about anatomy of ligamentum flavum, anatomy of the foramen, pathogenesis of lumbar canal stenosis, what is the relevant radiology, and how endoscopy is going to be useful. As we can see here, this is the picture of lumbar spine T2-weighted MRI. And this is the sagittal. This is the axial. This is the corresponding X-ray. And this is the AP view of the X-ray. As seen here, the lumbar vertebrae are very broad and they have a big body and a big footprint. In between, you have the disc space, and we have the facet joints and annulus fibrosis and intervertebral disc. We have a very broad lamina, and orientation of the facet joints of is paramount importance. And we have a spinous process, and in between, we have the collecting ligaments. This is the lateral view of the X-ray, which shows B represents the body. This is the disc space. This is the neural foramen. P stands for the pedicle, and this is the facet. And this is the superior facet, and this is the inferior facet. Superior articulating process, inferior articular process, and this is the spinous process. Similarly, we see here on axial MRI, we have to know these muscles because these are the muscles which we are going to discuss in endoscopic spine. This is the multifidus muscle and erector spinae muscle, quadratus lumborum. And this is the thecal sac, the facets, and the transverse process, and the intervertebral disc and the vertebral body. So as we can see, the canal is triangular. Gradually, when there is increasing level of canal stenosis, it becomes uptended and it becomes circular and then it becomes stenosed. Pars interarticularis is the bridging between the body and the pedicle and the lamina. This plays a crucial role in pathogenesis of lumbar degeneration and if there is any evidence of fracture. What are the ligaments that we are concerned about when we are dealing with lumbar anatomy? The most important thing is the ligamentum flavum. The yellow, it's also called the famously called yellow ligament. It stretches. So in the subsequent slides, we're going to read about ligamentum flavum and its anatomy. We should also know the supraspinous ligament, interspinous ligament, and between the foramen, there are the intertransverse ligaments. And then we have the facet joint capsule. We have the ligament that is anteriorly anterior longitudinal and posteriorly posterior longitudinal ligament. And these all constitute to the stability of the vertebral body. As we can see, the anatomy of ligamentum flavum is of paramount importance. We see the ligament has an outer layer and an inner layer, and it has two components. It resembles a butterfly, hence it is also called as a butterfly ligament. So the upper slip goes into the proximal lamina, that is the superior lamina. It is attached to the inner aspect. The outer aspect, the inferior point of the lamina stretches onto the superior part of the inferior lamina. It also has an extension to the foramen, and also there is a midline cleft where it is dehiscent, and it sends down suspensory or Hoffman ligaments, which has an attachment to the dura. Ligamentum flavum hypertrophy is one of the most common cause for the canal stenosis. So this is a cross-sectional view, and after removing the upper vertebrae, showing how there is a slip of ligamentum flavum underneath the superior lamina, and how inferiorly when it comes superiorly and blends into the superior aspect of the inferior lamina. We have to understand that there is extension even to the facet joints. There's also extension of the ligamentum flavum towards the neural foramen. Understanding the anatomy of the ligamentum flavum helps in easy removal. The midline cleft, this is where we are going to see in our endoscopic video why this is important. And this is a relative and avascular plane. We read this. And the functional unit of the spine, apart from the ligamentum flavum and the disc, is the neural foramina. As you can see, the neural foramina is divided into the upper, middle, and lower. The uppermost part has the nerve root, that is the exiting nerve root, and middle compartment has a superior branch of the segmental artery and also a venous plexus, and the inferior component is free of any neurovascular structure. Understanding this is of paramount importance whenever we are doing a foraminal approach to the lumbar disc and when you're doing a transcambian approach. And also when you're inserting a pedicle screw, we should ensure that there is no breach inferiorly because it's going to damage the nerve root here. The exiting nerve root can get irritated. And the point of interest to note are the multiple ligaments that are present within the neural foramen. They are divided into superior, middle, and inferior. They're called as the transforaminal ligaments. So superior transforaminal, middle transforaminal, and inferior transforaminal ligament. And any injury to the radicular artery causes tremendous bleeding and it has tendency to retract. Hence, identifying the site of bleeder is of paramount importance to prevent blood loss and inadvertent injury to the nerve root. So with degeneration, it can be a facetal hypertrophy, or it can be a disc prolapse, or it can be a pars fracture with a dense fibrous tissue or a pseudoarthrosis that results in gradual progressive obliteration of the neural foramen resulting in foraminal stenosis. This is again showing how the nerve root is being held by the intraforaminal ligaments. This is something of paramount importance to understand this. So neural foramen is not a simple structure. It has all these things in great detail. How about the blood supply? The blood supply to the disc space comes through the aorta. It has an ventral epidural artery which gives a branch to the radicular artery. So the radicular arteries are directly connected into the aorta and the venous plexus goes into the agigus vein. Each level has a segmental arteries. They are from L1 to L4. They arise from the abdominal aorta. L5 comes from the iliolumbar artery. And each of them provides a radicular artery to the branches and radicomedullary arteries which accompany the spinal nerve. We have mentioned this and we have seen this. And the venous plexus, they drain into the Batson venous plexus. This is of important route for transmission to cause the metastasis into the vertebral body from the prostate or the breast. What are the muscles that are very important to maintain stability? We have a multifidus muscle, and we have, this is the multifidus muscle that's in the close into the midline. This is the muscle of importance during endoscopic spinal surgery. Then we have dorsal spinalis, we have longissimus dorsi, we have the iliocostal and iliolumbar. Erector spinae forms a major thing. It is predominantly seen from T11 to L2 and inserts into the angle of the ribs and also to the spinous process and the transverse process at each level. They help in causing extension of the vertebral column. You can see here, we already described this, erector spinal location and multifidus location. So lumbar foraminal stenosis is defined as narrowing of the neural foramen and it results in potential nerve root compression due to back pain and radiculopathy. It can be due to disc, spondylolisthesis, osteophyte formation, and facetal hypertrophy. We have seen the various causes. This is the disc, this is the listhesis, this is the facet joint hypertrophy causing lateral stenosis, and this is the ligamentum lumbar hypertrophy causing central and lateral stenosis. So the stenosis can be central if it occurs in the center. It can be lateral or it can be foraminal. The foraminal stenosis is classically seen on the sagittal imaging. What are the types of structural failure? One, it can be annular tears. These are small fissures and rim tears, or it can be due to disc prolapse, or it can be due to end plate damage, or it can be due to internal disruption, that is annulus collapse into the nucleus. We can see the radial tears that happen, transverse tear that can happen, and you can see the disc bulge. Then we have the herniation migration of the disc, and this is a sequestration of the disc. So foraminal stenosis is also degraded based on type 1 to type 4. Type 1 is the initial and type 4 is very unstable foraminal stenosis. So what happens actually when which promotes the ligamentum lumbar hypertrophy? Whenever there is a mechanical stress or an aging or an inflammatory pathology or an oxidative stress, it releases cytokines and growth factors. And it reorganizes the extracellular matrix and it helps in coding of multiple RNAs which cause fibroblast differentiation. It increases the proliferation, it increases inflammation, and decreases apoptosis, resulting finally in fibrosis and hypertrophy of the ligamentum flavum. So this is the pathology of the cascade that happens in degenerative lumbar listhesis, which results in ligamentum flavum hypertrophy, or a degenerative spondylolisthesis, which results in hypertrophy of the ligamentum flavum. Here we can see the listhesis causing canal hypertrophy and facetal hypertrophy and ligamentum flavum hypertrophy. So why this UBE plays a role here? Now coming to the main part of the discussion, having had a background anatomy and the radiology and the structural ligaments that are responsible to maintain the stability, we will be discussing about why unilateral biportal endoscopy is a major step forward and how it is useful. It is a recent advancement in minimal invasive spine surgery. It is popularized by Koreans. I'm really grateful to the mentors. This is Dr. In 2019, and this is Dr. Park in Daejeon, where I received my formal training in biportal endoscopy. I'm really grateful to the mentors. So the outline on UB talk is going to be why we are choosing UB, what is the theater setup that is required. We're going to have an illustrative video demonstrating the surgery and what are the complications and what are the future directions. We all know that the Nokia, which was a major market holder in cell phones, had a steep downfall and is still not able to recover. This is the statement from the CEO talking, we didn't do anything wrong, but somehow we lost. What really happened is Nokia, although it was a very reliable model and although it is an old age phone, it did not adapt or adapt to the rising demands of the current generation. And because of which Samsung and Apple has overtaken, and now Nokia is seen nowhere as a competitor. So it is important to embrace the change. Similarly, although we are well versed with our open surgeries and traditional laminectomies and laminotomies, now the current world is moving toward minimal invasive surgery and a decay surgery. We need to adapt to the change and we need to embrace the change. So why UBE? It is a fluid-based surgery and it is not air-based surgery. Because of fluid, there's less blood loss and there is a field is clear and less chance of infection. It is a minimal invasive surgery. There's early return to work. It is less painful. And even in experienced hands, you can do in awake conditions. Very useful for those who are having more cardiac illness. It has a wide operative field and it has easy maneuverability, and accessing to the contralateral side is possible. And we can use regular laminectomy instruments and discectomy instruments as contrary to the uniportal system where you need to use a specialized instruments and which are costly. These are the few differences enumerating between endoscopic and open discectomy and endoscopic discectomy. The things to note is patients have high satisfaction rate due to less pain and quicker recovery. And multiple disc levels can be reached via the small incisions. Whereas in open discectomy, it requires extension of the incisions, thus increasing the blood loss and increasing muscle damage. This is an example from our operative series. As you can see through the right, the red is an open microdiscectomy that is being done. Superiorly is this is superior, this is inferior, medial and lateral. And you can see the nerve root and see the amount of blood. A similar view that is seen in our series from an endoscopic view where you can see the field is clear. We're able to appreciate the microneurovasculature and we're able to delineate the nerve root much better than open discectomy. And also the contralateral things are seen well. What are the instruments that you require? You definitely need an endoscope. 0 and 30 degree can be used. Some prefer to use 30 degrees, those who are trained in arthroscopy. I personally use 0 degree. You need a radiofrequency ablation system consisting of 90 and 45 degree probes. You need saline for irrigation. You need specialized UV instruments which are affordable and one-time investment. And regular laminectomy instruments can be used. This is a scope cannulas. These are part of the specialized UV instruments. These are the working cannulas named after Dr.Arun. These are the nerve retractors. These are the regular Kerrison punches. Of course, there is a foraminal punch too. These are rotatable punches which can be used to reach to the corners of the spine. We need a suction tip. We need curettes. This is the ball tip probe to probe the roots, Indian knife to make an annulotomy, disc punches, muzzle detacher to detach the multifidus muscle, serial dilators to increase the size of port, and double and long dissectors. What are the indications for UB? All degenerative lumbar, thoracic, and cervical can be used. Degenerative listhesis can be used for fusion. Facetal cyst, thoracic ligamentum flavum. In patients, especially very useful in patients who have adjacent segment disease with the previous pseudarthrosis, previous fusion surgeries where you don't have a virgin territory to access, you have to go through the scar. UB is very helpful to reach to the disease of interest or the index with the ease. And especially in old people who have multi-level lumbar disc prolapses, it's a very useful tool to avoid unnecessary fusion. What are the relative contraindications? Bleeding dialysis, infective pathologies, and intradural surgery. It's a relative contraindications. There are few who are doing tumor surgeries through biportal endoscopy. Caution about the case selection. Begin always with the left side L4, L5, then progress to cranial and caudal. Interlaminar first, followed by once you gain experience, go to foraminal. Contralateral is for few cases it is useful. The minimal amount of cases required to say that you're good at UB is at least 60, and experience you can start from lumbar, then progressively, once you gain experience, you can go to thoracic and subsequently cervical at the last level of your training. Study the MR carefully, look carefully for the corridor and plan your trajectories. For a few cases, contralateral approach is ideal. Look for calcified discs, study if there is any evidence of conjoined roots and if there is any calcification of the LO ligament. And if there is any evidence of scar tissue, try to avoid it and use always a virgin territory to make your dissection easy. We can use general anesthesia. Once you gain your experience, you can go to local. They need a need for special drape as it is a fluid-based surgery. You need C-arm to confirm the level, irrigation, drills, endoscope, RF, UV instruments. So you can see that we're using a special drape which has a cover on both sides. This is developed by Amralis here in India. And we mark the incision midline, and the superior end plate and inferior end plate of the level of interest is marked. Getting appropriate views is of paramount importance. And once the disc space is marked, we do the triangulation. The triangulation is done through the upper and lower middle, the upper and lower pedicles. Triangulation is very important. You have to have an ideal point at which they meet. The most common point is the spinolaminar junction. So this is the theater setup. You need to have a saline. You need to have a anesthetist at the cranial end. Then you have the nurse. You have the RF and the monitor, and you have the C-arm to confirm. So there would be an in and output port. So this will be a portal through which the water flows. There will be input of saline, and the saline has to go out. Ensuring the free flow of saline is of paramount importance. In the working space, usually the pressure is around 30 to 50 mm of Hg. You can serially elevate the level of the IV stand to get the adequate water flow. So once you confirm the level, you mark your skin, you create the portals, then triangulation, level confirmation, irrigation, and RF is working. And then once you get a clear view, you go for the identification of the bony landmarks. In an interlaminar junction, you have to identify the P, V, and J. We are going to read what is that. And in foraminal, it is important to identify the pars and superior articulatic process. And once you identify the bony landmarks, you use the shavers, you demarcate the flavum, do the flavectomy, identify the thecal sac and root, and proceed with the planned surgery. So how is do you identify the target level? As mentioned earlier, you need to definitely get a proper view where you see the superior and inferior end plate appropriately. What are the key steps? The most important step is making an incision to facilitate the saline flow. We prefer transverse incision rather than the vertical incisions because the fiber and facial dissection is good and it helps in flow of the water, and it helps not the water to accumulate within the paraspinal region. Ligamentum flavum should not be removed early. You have to finish the ligamentum, finish all the bony work, then only proceed with ligamentum flavum removal. And ligamentum flavum helps to prevent the sharp edge of the instruments and also the drill. And a special mention on triangulation, the entire success of the surgery depends on triangulation. So what do you mean by triangulation? Triangulation is a process where you separate. You can see this is a potential space. that exists, and it is called the Son space. This is in the between the fibers of the multifidus muscle. So we make a cranial incision and a inferior caudal incision, and we join both of them onto a spinolaminar junction. This is the process of triangulation. We need to dock our thing onto the lamina. As you can see here, this is the triangulation at L4, L5 disc space on the left side. So when you do the operation from the left side, which is the most common side, your scopy portal will be on the up and the working portal will be down. Always for a right-handed surgeon, the scope has to be held on with your left hand. And your working hand would be the right hand. And as you can see, the docking here or a triangulation here is a spinolaminar junction, whereas it changes in a foraminal approach, where you have a docking onto the pars interarticularis. So pars interarticularis is a docking for extraforaminal approach, whereas the spinolaminar junction is the docking for the interlaminar approach. So once you have docked, there's a small animations. We start drilling. We start creating the space. We start drilling the spinolaminar junction. Then we identify the ligamentum flavum, and we gradually remove the ligamentum flavum, and then proceed with over the top decompression and remove the discectomy. This is the ligamentum flavum that's excised. You see the disc, and we remove the disc. And once the roots are free, we inspect it and ensure the root is decompressed, and we ensure the surgery flow or the hemostasis is achieved, and then wound closure is done. So this is a brief technical note that has been reported about foraminal decompression. Today, point of discussion is the interlaminar approach. So we're going to discuss. This is a 26-year-old lady who had presented to us with complaints of back pain. And also the pain is radiating to the left lower limb for the past 6 months. Pain aggravates on standing or doing any work, and it is relieved on rest. And it is down the L5. And she had significant reduction in the claudication distance. She was in very severe distress when she presented to us. And as you can see, the MRI, the dynamic X-rays did not show listhesis. There was a severe left and paracentral disc prolapse, severe canal stenosis. These are instruments that we described. Patient is positioned prone, and triangulation is done in the point of interest. As you can see, we use the ports. This is being done by one of the fellow here. He's clearing off the muscles, stripping off the muscles to feel for the bone. And these both portals have to meet onto the midline, like a chopstick maneuver. And both of them, this is the chopstick maneuver. They both are meeting onto the midline. Then serially dilators are inserted. This is the scopy portal, and this is the working portal, specially developed by the Koreans. The scope is held in left hand. This is important. You need to get a good triangulation. So this is the perfect triangulation. You should not open triangle. That means you're not able to meet in midline. This is where you're crisscrossing each other. That results in a problem. So we need a perfect triangulation, and the triangulation has to happen onto the spinolaminar junction. So this is going to be the endoscopic view. This is a superior, and this is the cranial view. You can see the lamina, you can see the spinous process. Specialized Bond's drill is used. Ligamentum flavum is exposed. Going to the contralateral side, able to reach the contralateral very easily. Then using the drill to shave it out. Further drilling is accomplished. Ipsilaterally, we're drilling to see the edge of the lateral edge of the ligamentum flavum. So this is the C that I was talking about, how we create a C. The C represents the spinolaminar junction and the small facet. You can see the field is absolutely clear. There's no blood at all. This is the ligamentum flavum, and this is the V point. That is the head of the butterfly that is here. You can see that this is one wing of the ligamentum flavum. That is the opposite wing of the ligamentum flavum. This is the safe portal of entry. We can say the bony work is complete once we see this. And also typically the flavum goes cranially at least 3 to 5 mm to attach to the superior part of the lamina. And it is not necessary to drill completely up. Once you see this, you can stop the drilling. And now you can introduce your rongers in the safe entry point and gradually remove the ligamentum flavum. So these rongers should not be used for the regular cases and they have to be preserved for endoscopy. As you can see, they're very sharp. And just with gentle cuts, it just comes out and there's no necessity for you to keep on removing these fragments. They come out by the saline itself. This is epidural fat coming in view. That's the thecal sac down. These are the special RF probes to achieve hemostasis. The settings varies from case to case. This is reaching to the contralateral side very easily at the end of the surgery. The ligamentum flavum is removed and the annulotomy is done. The extruded disc is removed gently without creating any pressure. Using the disc ronger, all the residual disc fragments are also cleaned up. Can use a specialized thing to help in dissecting. And once the disc is removed, ipsilateral nerve root is inspected to see if there are any fragments underneath. Annuloplasty is done. And this is the J point. This is the J point that is removed in order to facilitate the nerve root decompression. So we saw the C point, we saw the V point, we saw the J point. Now going to the contralateral side, I found that the nerve root is still tense. So I retracted gently the opposite nerve root. Here it is being retracted. There was a disc fragment there. That was also removed subsequently. So the disc fragment is removed. Bilateral nerve roots are free. Then we achieve hemostasis using Surgiflow. And we place a drain. And this is the size of the incisions. They're less than 1 centimeter. Post-op MRI is done in order to see the decompression. See, there is no muscle damage at all. This is a small portal of entry. You can see there's only mild muscle edema. Patient did very well. So every approach has a complications. The mean incidence is comparable to the open approach. The most common complication was the dural tear. These are the meta-analysis showing the described complications. The most common complication is untreated pain and dural tear. And few patients had dysesthesia because of excessive nerve root handling. That has to be addressed by gentle handling. And if you don't remove the entire disc fragments, there can be chances of reherniation. So we did an anatomical study here by one of our colleagues here, by Dr.Arun, who has found that there was a dorsal dural tension bands and there is a dorsal dural bands which attaches to the ligamentum flavum. Identifying this and sectioning it while removing the ligamentum flavum at L4, L5, and L5S1 greatly reduces the amount of inadvertent CSF leak. These are also seen in the cervical spine and also in the thoracic spine, but well defined in the lumbar spine. So as a beginner and as a novice surgeons, it's important to realize this band and section it before you remove the ligamentum flavum. Surgical steps, muscle detachment is of paramount importance, portal widening with serial dilation, soft tissue with reduction of shavers and RF probe, meticulous hemostasis, and unimpeded saline flow during UB is of paramount importance. At any point you're not comfortable, you have to switch to microscope because you should not harm the patient. To conclude, UB is a safe surgery. It has a wider view and a clear view. It can be applied for various degen pathologies. You can access multiple levels of small incisions. You need a rigorous training and understanding the 3D anatomy is the key. Thank you for this opportunity, sir.
So, thank you, Professor Edmond. Your talk was very simple and exhaustive and very informative for all the people. So, it was a very nice discussion and
Thank you,
very
sir.
nice learning for our postgraduate students and also for the IMA members. Thank you so much for your participation in our neurosciences forum, sir. Thank
Thank
you.
you, sir. Thank you for the opportunity, sir. Looking forward.
Our second speaker will be Dr. Arun Ramraj, the consultant radiologist from Sri Ramakrishna Hospital. He is going to give a talk on newer insights of neuroradiology. His professional summary is accomplished radiologist with 20 plus years of experience in diagnostic imaging and interventional radiology, proven expertise in MRI, CT, PET CT, Doppler, and ultrasound with specialization in neuroradiology. Current position consultant neurologist, radiologist, Sri Ramakrishna Hospital, Coimbatore since April 2011 present. The professional experience, registrar radiology, Apollo Hospital, Chennai from July 2006 to March 2011, and radiologist part-time various hospitals and diagnostic centers, Chennai from 2006 to 2008. He had his education from the Stanley Medical College, Chennai, and Madurai Medical College, DMRD, and DNB Radio Diagnosis, Apollo Hospital, Chennai. Key achievements and academics: invited speaker at multiple national and state radiological conferences, IRIA, ISNR, research MR imaging of the spinal bone marrow disorders, award-winning academic presentations and the quiz recognitions. The professional affiliation, Indian Radiologists and Imaging Association, IRIA, Indian College of Radiology and Imaging, ICRI, Indian Society of Neuroradiology, ISN. Now I invite Dr. Arun Ramraj, who is going to give a talk about newer insights in neuroradiology. Welcome you, sir.
Am I audible, sir?
Yes.
Okay, sir. First, I thank Dr. Rajesh, sir, and Dr. Vikram for having me here. The topic given to me is newer insights in neuroradiology. I will go by a case-based approach. First is case number 1 is a 10-year-old male child who developed sudden right hemiparesis while in school. And the patient was referred for MRI. In the MRI, we are able to see a diffusion-weighted image. There is an acute infarct in the left lentiform nucleus extending to the caudate nucleus. And if you see the MRA image here, this is the MRA image here. The right MCA appears normal. Left MCA, there is subtle irregularity in the proximal M1 segment. So this is the vessel wall imaging sequence, which is a newer sequence, vessel wall imaging sequence. This is a plain study and this is a contrast study. This is the lenticulostriate artery. This is a plain study. This is a contrast study. As you see here, there is circumferential wall thickening and enhancement of the lenticulostriate artery. You compare with the adjacent vessel, this artery is definitely having a wall thickening and enhancement. So it is a case of vasculitis involving the lateral lenticulostriate artery. So it is a case of focal cerebral arteriopathy of childhood, in which there will be unilateral stenosis of the distal ICA or its proximal branches, causing lateral lenticulostriate artery territory infarction. And the lateral lenticulostriate artery is a branch of M1 segment of MCA, and it supplies the lentiform nucleus, part of caudate nucleus, and posterior lymphoid capsule. And it commonly occurs post-varicella zoster vasculopathy. There will be concentric wall thickening with enhancement of the vessel wall in vessel wall imaging. So coming to this is an image of the patient. This patient had a chicken pox a few months back. So coming to vessel wall imaging is an advanced neuroimaging technique. Here we will say this is a pulse sequence with the black blood and black CSF. We will suppress the signal from the blood and CSF. We will do pre and post contrast. And these are the various pathologies and their appearance in the vessel wall imaging. So we will see this with an example. Here is a 41-year-old female who presented with left MCA territory infarct. See, there is an infarct in the left MCA territory. In the MRA, there is narrowing in the cavernous segment of left ICA and in the M1 segment of left MCA. This is a vessel imaging sequence. There is eccentric wall thickening. See, there is eccentric wall thickening in the left MCA, and there is a subtle T1 hyperintensity. With contrast, there is enhancement. So the eccentric wall thickening with enhancement suggests it is a case of intracranial atherosclerosis. We compare this with another patient. It's a 55-year-old male having infarcts in bilateral cerebral parenchyma. MRA, there is total occlusion of the right, near total occlusion of the right MCA. In the vessel wall imaging, we are able to see circumferential wall thickening with enhancement suggestive of vasculitis. So another patient, 55-year-old male, with the known case of right dorsolateral medullary infarct, and MRA shows the source image shows a flap in the V4 segment of right vertebral artery, and the vessel wall imaging sequence show eccentric wall thickening with luminal narrowing and an intramural T1 hyperintensity suggestive of hematoma, and which may show enhancement with contrast. So it is a case of vertebral artery dissection causing right dorsolateral medullary infarct. So the take-home point here is vessel wall imaging is useful in differentiating atherosclerosis or dissection or from vasculitis. So we'll go to case number 2. Case number 2 is a 2-year-old male had a trivial fall while playing in his home. While playing in his home, he was running and he fell down and he developed right hemiparesis after a trivial fall. So this is a diffusion weighted image showing infarcts in bilateral lentiform nucleus with corresponding ADC, low ADC values. MRA appears normal. See the susceptibility weighted image here. Susceptibility weighted image, there are dark areas here, and here there are some bright signal intensities. It says it is a calcification. See the T1 weighted image, we are able to see the infarcts here. Apart from the present acute infarcts, we are able to see a old infarct in the right base ganglia involving the right cardiac nucleus and in the lentiform nucleus. And this is CT of the same patient showing calcifications along the basal ganglia bilaterally. So it is a case of mineralizing microangiopathy infarction, which is a rare cause of childhood stroke, common in 6 months to 2 years of age. And there will be hemiparesis followed by trivial trauma. The perforating arteries arise from the MCA in acute angles in children. That is a cause suggested for mineralizing microangiopathy. And here CT is investigation of choice. Otherwise, you have to look for the susceptibility image and to differentiate between calcification and hemorrhage. So linear calcifications along the course of lenticulate striate arteries is a glitching point here. So another rare cause of infarct which can be diagnosed using a image that is by CT or susceptibility image. Next is a case number 3. Is 50 years female with right hemiplegia and left hemianopia. See, usually if you see a patient with an MCA territory infarct, the patient will present with hemiplegia or hemiparesis. In case of PCA territory infarct, the patient will present with vision abnormalities like homonymous hemianopia. This patient is having hemiplegia and hemianopia. So this is the diffusion weighted image. Here is the areas of restricted diffusion is seen involving the lateral aspect of midbrain, amygdala, hippocampus, optic radiation, posterior limb of ventral capsule, and lateral aspect of thalamus. See, the MRA appears normal. So this vascular territory is typically anterior choroidal artery territory. See, the anterior choroidal artery arises from the posterior wall of terminal segment of internal carotid artery just before its bifurcation into ACA and MCA. So it supplies the hippocampus, amygdala, optic tract, posterior limb of ventral capsule, lateral thalamus, lateral aspect of midbrain, and it is typically called as anterior choroidal artery syndrome. We have contralateral hemiplegia, hemianesthesia, and ipsilateral hemianopia, and usually it will be incomplete due to rich anastomotic vascular supply. It is very rare to have an extensive anterior choroidal artery infarct like this. Usually it will be a small lacunar infarct. And why it is important? It is often confused with an MCA or PCA territory infarction. So we have to be aware of this anterior choroidal artery territory infarct. Next is a case number 4. It's a 46-year-old female who presented with double vision, who gave history of double vision 3 days back, and he was brought unresponsive now. And this is the MRI images, diffusion weighted image showing acute infarcts involving bilateral medial thalami and extending to the rostral midbrain. This is a FLAIR image showing the same infarcts involving the rostral midbrain and the bilateral medial thalami. MRA was normal. So it is a case of artery of Percheron infarcts. What is artery of Percheron? Artery of Percheron is a solitary arterial tongue supplying bilateral paramedian thalami and rostral midbrain. Occasionally, it supplies anterior aspect of thalamus. See, normal, it is just single artery percutaneous is a single arterial trunk which supplies bilateral medial thalami. That's why both thalami are getting infarcted. Coming to thalamus arterial supply. The interesting part here is the anterior aspect of thalamus will separate from the anterior circulation. It is separated by tuberothalamic artery from the posterior communicating artery. Medial is from the paramedian artery from P1 segment. Posterior and lateral are from the P2 segment. So going on for another infarct case is a case number 5. Is a 33-year-old male who is a known large vessel vasculitis, known case of large vessel vasculitis, and he developed sudden onset amnesia. As you see here, is a 33-year-old male. The diffusion weighted image. Here, the foci of restricted diffusion is seen involving the column of fornix, anterior aspect of the corpus callosum, and caudate nucleus, and some part of the lentiform nucleus here. So it is a case of, so the infarct territory is in the ACA territory, but it is a typical subcallosal artery territory infarct. See, the patient is having a known case of vasculitis. See the bulbous dilatation of the terminal segment of internal carotid arteries. ACA are totally occluded. Bilateral ACA are occluded. See the significant narrowing in the left MCA. All this suggests a case of, in an individual, is a case of vasculitis, and it is a case of subcallosal artery infarct. Subcallosal artery is an unpaired perforating artery from the anterior communicating artery, and it supplies bilateral column of fornices, anterior corpus callosum, and septum pellucidum, and is usually associated with recurrent artery of tubular infarction as it arises from the A1 A2 junction. Most of the cases are cardioembolic, and commonly this type of subcallosal artery infarct commonly occurs after clipping of ACOM aneurysm or after treatment of ACOM aneurysm. So with this, we have done with the arterial infarcts, and we will see the rest of other cases. This is a case number 6. It's a 29-year-old female who presented with mild left hemiparesis since 4 hours. So it is a acute setting within 4 hours, and this is a diffusion weighted image. And as we see here, there are foci of restricted diffusion involving the right frontal and parietal lobe, typically involving the MCA territory. But if you see the ADC here is not completely dark. It is a mixture of bright signal and dark signal. And this is a susceptibility image showing hemorrhage in central aspect of the infarct. So in the central aspect of the infarct, there is hemorrhagic transformation. The history is very less. It is less than 4 hours. So this is a MRA showing normal right MCA. So MRV showing the superior sagittal sinus. And this is a coronal flare images. In the coronal flare images, we are able to see some abnormality here. So this is the usefulness of acquiring at least one image in a coronal plane. At least one image in a coronal plane. See, there is some abnormality here in the cortical vein, and with contrast, we are able to pick up the cortical vein thrombus here. So there is a cortical vein thrombus with an hemorrhagic venous infarct mimicking as an acute infarct. So after seeing this, we went and asked the patient whether she had seizures, and she told she had headache and followed by seizures, and then only he had neurological deficit, which is very mild. So the take-home point here is cortical vein thrombus will present with seizures and focal neurological deficit. Even though it is mimicking like an MCA territory infarct, we have to identify the difference between an arterial infarct and venous infarct. Cerebral venous thrombosis is less common than arterial infarcts and is common in young adults, particularly in females. The clinical features will be headache, seizures, focal neurological deficits, decreased level of consciousness when there is involvement of the deep venous system, memory impairment and aphasia, involvement of temporal lobe, neuroophthalmic symptoms in the cavernous sinus thrombosis, occipital and cervical pain in case of transversinus or sigmoid sinus thrombosis. So the pathology behind and CVT, that venous hemorrhagic infarct, is initially due to the thrombus. There will be increased venous resistance and there will be vasogenic edema due to that. And once the pressure increases the capillary arterial pressure, then there will be a development of cytotoxic edema and further into intraparenchymal hemorrhage. So venous infarct will always have a mixture of vasogenic and cytotoxic edema. And the coming to cortical vein thrombosis, as I mentioned earlier, the clinical symptom will be seizure and focal neurological deficit. Arterial infarct won't have seizures. So this is a left MCA territory infarct. For comparison, you see this case. This is a wake-up stroke. Wake-up stroke. He went to bed normal, and in the morning, as he has noticed hemiplegia, and as you see here, there is a dense hemiplegia in the left MCA territory, and there is total occlusion of the left MCA here. There is thrombus in the left MCA, and as you see here, see the ADC here. ADC here is completely dark, and it has a sharp margin. It has a sharp margin. That's so the difference between venous infarct and arterial infarct radiologically is in venous infarct, the patient will have seizures. Arterial infarct, seizure won't be there. And venous infarct will have hemorrhage, and the hemorrhage will be from center to periphery of the infarct. Arterial infarct, hemorrhages are uncommon in the first 6 hours, and it begins in the margins. And venous infarct, the vessels, there is a cortical vein or venous sinus thrombosis, cortical vein thrombosis will show a clot sign similar to the hypertensive MCA in arterial infarct. And in diffusion-weighted image, due to the presence of vasogenic and cytotoxic edema, venous infarct will have a mixture of dark signal and bright signal on ADC. Arterial infarct will have cytotoxic edema. And due to the presence of vasogenic edema, the margins will be irregular in venous infarct. In arterial infarct, it will be sharp. So coming to hemorrhagic transformation of an arterial infarct, it occurs in first 4 days. It is commoner in 24 hours post thrombolysis or thrombectomy, and is rare in first 6 hours. Hemorrhagic it is differentiated into 2 types: hemorrhagic transformation, hemorrhagic infarct 1 and 2, and parenchymal hematoma. Parenchymal hematoma 2 carries poor prognosis, and we have to be aware of other condition called contrast staining, which occurs post mechanical thrombectomy. And dual energy CT is useful in differentiating contrast staining from mechanical thrombectomy. So this is a case of right MCA territory infarct with a small petechial hemorrhage. It is transformation, that is hemorrhagic infarct 1. And if the petechial hemorrhage, another patient, if the petechial hemorrhages have become more confluent, then it is hemorrhagic transformation, that is hemorrhagic infarct 2. And if within the infarct, if there is a parenchymal hematoma, which is it is not a petechial hemorrhage, if there is a parenchymal hematoma involving less than 30% of the infarcted area, then it is called parenchymal hematoma 1. And if the hemorrhage is involving more than 30% area of the infarct, then it is called parenchymal hematoma 2. And this PH2 carries poor prognosis due to presence of mass effect. And as you see here, there is intraventricular extension of the hemorrhage as well. So the idea behind this case is to differentiate between a venous infarct and arterial infarct in an acute setting. First is venous infarct patient will present with seizures. Cortical vein thrombosis will present with seizures. Arterial infarct won't have seizures. And if you see the ADC value, see here, it is a mixture of bright and dark signal. And in arterial infarct, it will be dark signal intensity with sharp margins. Here the margin is irregular. And the hemorrhage is common in venous infarct in the earlier stage. And in coming to arterial infarct, hemorrhagic transformation is uncommon in first 6 hours. So we'll go to case number 7. Case number 7 is a 53-year-old female who presented with severe postural headache. And see, this patient has come for CT. The neurosurgeon has planned for a STH evacuation. The patient is having a STH bilaterally. One is subacute on the left side and chronic on the right side. And as you see the CT here, there is no trauma. As you see the CT here, there is some drooping of splenium of corpus callosum, and there is some obliteration of the suprasellar system. So we thought we will do an MRI. So after discussing with the operating surgeon, we went ahead and did an MRI, and MRI showed bilateral subdural hemorrhagic collections. And as you see here, there is sacking of the midbrain. And as you see here, the coronal images showing the subdural collections, and see the dural venous sinuses here. Dural venous sinuses are dilated. See, once again in the sagittal image, we are able to appreciate the drooping of splenium of corpus callosum. And as you see here, there is a vascular hinge here, and there is obliteration of the suprasellar system. See, the suprasellar system is obliterated, three-pontine system is obliterated, and there is a reduction in the pontomammillary distance. All these features are features of intracranial hypotension. As you see here in the sagittal image, the dural venous sinuses normally will have a concave superior margin. See, superior aspect will be concave. Here it is convex, so the venous sinuses are dilated, and with contrast, there is meningeal thickening and enhancement. And so we went ahead and did the spine screening, and we are able to see an spinal longitudinal extradural collection. There is an extradural collection here. See, there is an extradural collection here, and we did a CT, and we are able to appreciate a spur which has caused the ventral dural tear, resulting in spontaneous intracranial hypotension. So the spontaneous hypotension, there is a score called a Burns score, and depends on depending on the findings here, and there is a score, and when the score is less than 2, the probability of detecting a leak is less. So if the points are more than 5, then it is high risk, and we will be able to pick up the tear. So once you pick up the tear, how to pick up the tear? We have to do a dynamic prone CT myelogram. And first one is a ventral dural tear, which we have seen in our case. Second one is a near root sleeve tear. It will be in the lateral position. As you see in this case, showing bilateral subdural hemorrhage, and there is a leak of the myelogram contrast in the here. It is a nerve root sleeve tear. And third one is a CNS venous fistula. And there are some conditions which are known to coexist with spontaneous intracranial hypotension. One is the cerebral venous sinus thrombosis, and 2 is a pituitary enlargement and apoplexy, and 3 is a superficial cirrhosis. As you see here is another patient, young female with intracranial hypotension. The pituitary is enlarged and it is appearing hyperintense on T1, suggestive of hemorrhage. Secondary to intracranial hypotension, there is pituitary apoplexy is there. The same patient is showing a thrombus in the transverse and sigmoid sinus. So you have a coexisting condition of intracranial hypotension with transverse sinus thrombosis and pituitary apoplexy. Another elderly male with recurrent STH operated, and on MRI, as you see here, this patient developed with memory impairment, hard of hearing, and ataxic gait, and history of frequent falls. And as you see here, there is chemosiderin deposition along the cerebellar foliae, along the surface of the brainstem, and involving the supratentorial cerebral sulci. So it is a case of superficial cirrhosis, which is also known to associate with spontaneous intracranial hypotension. So whenever you have a spontaneous subdural collections, bilateral subdural collections, we have to think of spontaneous intracranial hypotension, and the other differentials for subdural collections are a case of another case of dural venous sinus thrombosis. There is a subacute thrombus involving the transverse and sigmoid sinus with dural thickening, tentorial and dural enhancement, and dural sinuses can cause dural thickening and tentorial enhancement, similar to spontaneous intracranial hypotension. Similarly, dural metastasis, as seen in this case, is a case of CA prostate with dural metastasis can have bilateral subdural collections. And similarly, dural leukemia, the upper row is a plain study, and this is the contrast study, is the dural leukemic deposits, which is causing hemorrhage with subdural hemorrhages bilaterally. Rarely, a ruptured aneurysm can also have bilateral subdural collections. So in this case, the take-home point is bilateral subdural collections, spontaneous subdural collections. You have to think of subdural. You have to think of spontaneous intracranial hypotension. We have to do the entire screening from the spine, and you have to do, if possible, you have to do a CT myelogram and to find out the dural leak. And the treatment here is, if the patient is not responding to medical treatment, they will do they will first localize the tear, localize the site of CSF leak, and they will do an guided procedure at that level. So next is a case number 8. So next to the case number 8 is a 53-year-old male who is a known diabetic, hypertensive, and dyslipidemia. And this patient was working in the Middle East, and their family was here in India. And he developed left-sided weakness 15 days back. And CT done at that time showed an established infarct in right coronary aorta, and they treated as acute stroke. But after 15 days, he developed right-sided weakness with difficulty in walking. Now they went ahead and did an MRI. This is MRI images in which there is involvement of bilateral periventricular white matter. The bilateral coronary aorta is involved. And as you see here, there is a typical foci of restricted diffusion bilaterally, like being like an onion bulb. Onion, see, it is like an onion. There is an area of hyperintensity, hypointensity, then hyperintensity. There is mild edema on the right side. See the corresponding T2 weighted image showing concentric areas of hypointensity, hyperintensity, hypointensity, hyperintensity, hypointensity. There is mild edema on the right side, and the Same thing better appreciated in the T1 weighted image, and with contrast, there is enhancement of these areas. So here, so any lesion with the restricted diffusion in the leading edge, it is a case of demyelination, and it is one of the rare cases of Ballow's concentric sclerosis. So Ballow's concentric sclerosis is a rare aggressive variant of multiple sclerosis, and there will be alternating layers of demyelination and preserved myelin. And the classic imaging feature is a concentric onion bulb appearance on T2 weighted image and FLAR image, and there will be ring enhancing lesions with variable central restricted diffusion. The next case is a case number 9. Is a 70-year-old male who presented with left hemiparesis, and it is gradually progressive. This is a T2 weighted image, in which we are able to see a large ill-defined T2 hyperintensity involving the right cerebral white matter. See, the lesion is involving the white matter. Cortex is preserved, and there is midline shift. There is mass effect over the right lateral ventricle, midline shift, subfalcine herniation. And if you see the diffusion weighted image here, see there is leading edge restricted diffusion. See there are some foci of restricted diffusion here and there. Always you see the leading area. The leading edge is showing restricted diffusion. And if you see the pons, pons, there is heterogeneous enhancement. And if this is a zoomed up image, see the pons. This is a trigeminal nerve. Whenever the intrapontine trigeminal nerve is involved, it is more likely to be demyelination. See the open ring here. So it is a case of demyelination. This patient underwent biopsy, and it was proven as demyelination. So it is nothing but it is a Marburg variant of multiple sclerosis, which is also a rare acute variant of multiple sclerosis. And there will be rapid progressive course with frequent severe lapse leading to severe disability or death due to brainstem involvement or mass effect or herniation, and is often preceded by febrile illness. So we have seen two rare variants of multiple sclerosis. So how to diagnose multiple sclerosis? Previously, by morphology, how we was diagnosing. So whenever you do an MRI brain, there will be multiple areas of non-specific hyperintensity in bilateral cerebral white matter. So the main aim is to differentiate demyelination from other non-specific things. So first is, whenever you see a periventricular lesion which is ovoid in shape, periventricular white matter lesion which is ovoid in shape, and if there is involvement of the juxtacortical white matter, lesions more than 1.5 centimeter in size, and if there is involvement of the temporal lobe, because in case of small vessel ischemia, temporal lobe will be preserved. So if there is involvement of the temporal lobe and brainstem lesions which are touching the surface, the brainstem lesions which will touch the surface, it is demyelination. And if you see the callosociptal interface, there is the involvement of the Dawson's finger or dot dash sign. So all these features are typical of multiple sclerosis. So multiple sclerosis, juxtacortical, periventricular ovoid lesion, temporal lobe involvement, size greater than 1.5 centimeter, brainstem lesions abutting the surface, callosociptal interface lesions, Dawson's finger, typical nodular or open ring enhancement. And coming to optic now, there will be unilateral involvement with optic neuritis, and spinal cord lesions. The spinal cord lesions will extend for less than 2 vertebral body height in the sagittal plane, and in the axial plane, the lesions will be typically in the dorsal or lateral aspect. So coming to the newer ones, things like central vein sign and paramagnetic rim lesions. These are imaging biomarkers which are recently included in the McDonald criteria for multiple sclerosis in 2024. Central vein sign helps in differentiating multiple sclerosis from small vessel disease, NMOSD, and SLE. How to identify this? You have to identify this in a 3D sequence, whether it has to be SWA or EPI sequence, or we can see in the FLAR sequence. The rule is we have to see at least 6 lesions with central vein sign. We will see the paramagnetic lesion later. So as you see here, it is a known case of multiple sclerosis. See here, there is involvement of the cerebellar white matter. See, there is involvement of the pons. The lesions are touching the surface, and there is involvement of the periventricular and juxtacortical white matter. And see the susceptivated image here. See the block here. The demyelination. See the demyelinating area. Center, we are able to appreciate tiny dark signal. It is a central vein sign, which is seen in the susceptivated image. See the 3D sequence of the FLAR sequence here. See the FLAR sequence here. This is just a zoomed up image. See just a zoomed up image. See the lesion here. We have zoomed up the image, and there is a central vein here. Similarly, there is a central vein here. There is central vein here. See another the same patient, another image, another demyelinating lesion. Seeing here, showing a central dot sign, cerebellar parenchymal lesion showing central dot sign. Here also central dot sign. So the presence of central vein sign is an important feature now included in the McDonald criteria 2024 in differentiating multiple sclerosis from other white matter leukoencephalopathy. Similarly, paramagnetic lesions. What is paramagnetic lesions? Sclerosis. See, there is a lesion in the right temporal periventricular white matter and one in the right cerebral peduncle. See, this right cerebral peduncle has a dark rim due to presence of iron-laden microphages. See here, due to dark rim here, it is a paramagnetic lesion. Rim lesions are now included as a biomarker for multiple sclerosis. And if there are some of these lesions due to presence of iron can appear dark on T1. See, this is a dark T1 weighted image, also showing a dark signal here, dark periphery here. So paramagnetic rim lesions are, this is particularly useful in radiologically isolated syndrome. Whenever the patient with a radiologically isolated syndrome, that is only brain lesions, only imaging ways that is looking like a white matter lesion, and there is no clinical features of multiple sclerosis. Then if you see a paramagnetic rim lesions, these patients are more likely to get into multiple sclerosis in the next 5 years. So we are done with demyelination. We will go to the tumor imaging now. Is a case number 10. It's a 56-year-old female who presented with right hemiparesis. On CT, there is they have done a CT and there is a left basal ganglia SOL. And this is a diffusion weighted image. The diffusion weighted image, there is some abnormality seen in the subcallosal area and septum pellucidum extending to the left basal ganglia. So subcallosal area, septum pellucidum, and left basal ganglia showing solid restricted diffusion. That is solid restricted diffusion. And on the T1 and T2 weighted image, in the T2 weighted image, the lesion appears mildly hypointense on T2 with mild. See, there is mild edema here. There is mild edema here. And with contrast, the lesions show nodular enhancement. And on the sagittal image, there is a notch here. This is called notch sign. There is a notch here. And there are a few other lesions seen in the temporal lobe and in the pons. See, all these lesions are touching the CSF. See, this lesion is touching the ventricular margin. Here it is closer to the sulci. Here also it is closer to the cistern. So all the lesions are touching the CSF. So it is a case of, so this is a perfusion image showing this is a lesion here. Perfusion image, the perfusion is definitely increased, but if you see the percentage signal recovery curve, I will come to this curve later, and see the curve here. Normally, once you give the contrast, this is a T2 weighted image, this perfusion. So there will be drop in the signal, and after some time, the signal will recover. And depending on the percentage of signal recovery, as you see here, the percentage signal recovery curve overshoots the baseline here. So this is the baseline here. From here, it is getting down, and after that, it is overshooting the baseline. It is seen typically in a case of lymphoma. So it is typically seen in a case of CNS lymphoma. So coming to primary CNS lymphoma, the lesions will contact the CSF surface, and relatively, there will be less peritumoral edema and mass effect. And due to presence of highly cellular nature, it will have solid restricted diffusion, and there will be variable strong enhancement. And the perfusion. The perfusion will be high, but it will be low when compared to the high-grade glioma and metastasis. So high-grade glioma and metastasis will have more perfusion than the lymphoma. The signal intensity curve exceeds the baseline. So we will see this with the example. So these are the various enhancement patterns which are described in the case of CNS lymphoma. This is nodular pattern, ring pattern. This is the notch sign, which we have seen in our case. Open ring pattern. So open ring pattern is typically seen in demyelination. However, in case of tumor, the ring will be thick. There is a gyriform pattern of enhancement in a lymphoma. So we have the newer thing here is a perfusion imaging. It's a tumor perfusion imaging. So the perfusion imaging is useful in grading of a tumor and to prognosticate and to help the operating surgeon for biopsy guidance, where to do the biopsy, and to differentiate between recurrence and radiation necrosis, and to assess the response to treatment, that is whether it is pseudo progression or pseudo response, and differentiating GBM from metastasis and lymphoma. So this is what I have explained previously, and as you see here, lymphoma will overshoot the baseline. That is, its recovery will be more than one, and more than one. See, it is be recovery. See, the recovery here is more than 100%. Low grade glioma, high grade glioma, and metastasis. So the recovery will be farther from the baseline in case of metastasis. We'll see this with an example. Here is an elderly male who presented with a stroke-like symptom, and we have done a stroke protocol initially. And as we see here, there is a foci of restricted diffusion here. So we thought it could be infarct, but as you see here, there is cortical thickening here. So we have a doubt, and we went and did a CT. And in the CT, there is a cortical thickening here. So definitely it is not looking like an infarct, and we give contrast, and in the contrast, there is heterogeneous enhancement. And on this PET image, there is a FTG PET image, which there is showing an uptake in the FTG here. So it is a case of, definitely it is a case of malignancy. And it is see the perfusion image here. See, this is the enhancing area here. This is a percentage recovery here. It is well below the baseline. This is the baseline. It is well below the baseline. And see always in the case of glioma, you see the enhancing portion here. See, the enhancing portion here is showing high perfusion. High perfusion means it will be bright red in color. It will be bright red in color. Blue is low perfusion. Green is intermediate. So if you see, there is a high perfusion here. See the surrounding area. See the surrounding area here. The perfusion here is higher when compared to the contralateral side. So it suggests here it is a malignant lesion which is having an infiltrative pattern. That's why the perfusion is higher in the surrounding area. So it suggests it is a case of high-grade glioma. You compare this with another patient with a similar nodular enhancing lesion in the left parietal lobe. Here, the lesion also showing restricted diffusion. There is nodular enhancement, and there is surrounding edema. And as you see here, see the perfusion image. See the perfusion image. See the perfusion image. The perfusion image showing an increase in the perfusion. See the surrounding area. The surrounding area is not having high perfusion when compared to the contralateral side. So metastasis don't show increased perfusion in the peritumoral edema. So this is a take-home point, how to differentiate between a metastasis and high-grade glioma. And this patient turned out to be a case of CA lung. So the difference here is high-grade glioma, peritumoral area will show high perfusion. Metastasis, peritumoral area don't show high perfusion. And high-grade glioma and metastasis will have higher perfusion when compared to lymphoma. And lymphoma will overshoot the baseline. So another patient is a 50-year-old patient. See, there is a solid restricted diffusion here in the splenium of corpus callosum. See, we thought it could be a lymphoma. So patchy enhancement, variable enhancement, patchy enhancement here. But as you see the diffusion weighted image, there is some high signal here, and the corresponding ADC also showing a low signal extending from the lesion to the cortex. See, there are some areas of T2 hyperintensity extending from the lesion to the cortex, and this area is also showing increased perfusion when compared to the contralateral side. So here also the lesion is infiltrative in nature, and due to increased perfusion, it is very bright red in color. So it is a case of infiltrative glioma that turned out to be GBM. So that's how we differentiate GBM from metastasis or from lymphoma using perfusion imaging. The other indication of perfusion imaging is post-treatment imaging. As you see here, this is the adenoid cystic carcinoma of lacrimal gland. It was operated and treated with radiation in 2022, and in May 2024, the patient presented with a lesion in the left frontal periventricular white matter. See the restricted diffusion here with the mass effect, midline shift, and there is a typical frond-like enhancement pattern here. And as you see here in the perfusion image, there is no increase in perfusion. And on spectroscopy, there is no increase in choline peak or choline creatine peak, and there is only increase in the lactate peak. See, there's a LL means lipid lactate. So there's increase in lactate peak. And if you see so it is a case of radiation necrosis, and this is a radiation planning CT. If you see carefully, the entire lesion is fitting within the radiation field, so suggestive of radiation necrosis. So that's how we differentiate a case of radiation necrosis with recurrence or residue. So with this, we'll move on to the next case. This is about how serially we can look for recurrence or infiltration or disease progression in an MRI in a tumor. Here is an 18-year-old female who presented with seizure. This MRI was done outside, and there is a abnormal mass lesion, T2 hyperintensity mass lesion here in this part of brain in the left side. There is subtle increase restricted diffusion here, and there is some signal alteration along the left paraphalcine region. So they had not done the perfusion, and this image was taken in January 2023. And after 6 months, we have done a follow-up. Now this lesion has increased in size. There is definitely the restricted diffusion now, and definitely there is some hemorrhagic component appearing within the lesion, and the paraphalcine signal density is appearing same. Now the enhancing component has also increased in size, and see the perfusion is higher in this area. So if you do biopsy, we have to get biopsy from this area showing high cellularity due to restricted diffusion, hemorrhagic component, increased perfusion. And we have done the same, and it turned out to be a case of grade 3 astrocytoma. And in the immediate post-op period, so this MRI was taken, usually in the immediate post-op period, you have to take within 48 hours or 72 hours. And this is the immediate post-op period. This is a post-operative cavity here. So in the edge of the post-operative cavity, we are seeing foci of restricted diffusion. We have to think of whether it is a tumor residue or recurrence, or these are not tumor residue or recurrence. This is done in the immediate post-op period. In the immediate post-op period, the surgical blood, the operative blood will have hemorrhage and devitalized tissue. This is a devitalized tissue, which may show some enhancement, and you have to follow it up. See in the follow-up image, see the post-operative cavity has become gliotic with the increase in the exacodilation of the adjacent ventricle, and the enhancement is now reduced, and there is no associated diffusion now. So it is a post-operative cavity. And if you see here, see the same left paraphantic, this thing is persistently seen. And now you see the perfusion here. The perfusion here is showing increased perfusion in this area when compared to the contralateral side. And on follow-up after another 6 months, now we have got an area of restricted diffusion in the same area with an enhancing component. So here, perfusion image is preceding the diffusion weighted image and conventional T2 weighted image and contrast in identifying the disease extent of the disease. So another 2 months, the patient has a mass lesion in the left paraphalcine frontal lobe, and now this lesion is crossing the contralateral side, the restricted diffusion and increased perfusion. And on May 1, 2024, we are able to see a large lesion extending from the left frontal to right frontal region. So the advanced neuroimaging technique like diffusion weighted image or perfusion are helping us in identifying the disease progression of a tumor. So coming to the case number 11, is a 29-year-old male who is a known who had seizures, and he presented with altered cognition. So young male with seizure, and as we see here, there are flare hyperintensity areas seen involving the cortex and subcortical area of left temporal lobe and right paraphalcine frontal lobe. The same thing seen better appreciated in the coronal images. See the coronal images here, showing the involvement of left temporal, cortical, subcortical, chiral thickening, swelling, T2 flare hyperintensity. And with contrast, there is some patchy leptomeningeal enhancement here, some enhancement here, and some opening enhancement here. And it turned out to be a case of MOG antibody disease. MOG antibody disease, it is a MOG antibody related MOG encephalitis is called FLAMES. FLAMES is flare hyperintensity lesion in anti-MOG associated encephalitis with seizures. The MOG can present as encephalitis, and the patient will present with seizure with headache, fever, and cortex-related neurological symptoms. So what is MOGAD? MOGAD is a myelin oligodendrocyte glycoprotein antibody associated disease. It will have varying presentations. In the childhood, it is present like a ADM. And in infratemporal lesions, there will be involvement of the thalami, pons, and middle cerebellar peduncle. Optic nerve, there will be bilateral anti-aspect of optic nerve will be involved with perioptic neuritis. There will be sparing of the optic chiasma and retrochiasmatic region. Optic chiasma, retrochiasmatic region, and medulla are commonly involved in NMOSD. In MOGAD, there will be sparing of optic chiasma and retrochiasmatic region, and clinically there will be optic disc edema. Coming to spinal lesions will have longitudinally extensive transverse myelitis with central cord involvement and predominant conus involvement. NMOSD will involve the area postrema. As you see here, another patient with MOG disease showing a longitudinally extending involvement along the spinal cord, involving central aspect of the spinal cord. See the involvement of the conus here. Area postrema is paired. The same patient showing large white matter lesions involving the periventricular and subcortical matter, involvement of upper midbrain and pons. See the perioptics neuritis here. Another young child showing ADM like picture here. As you see here, there are large white matter lesions involving bilateral cerebral parenchyma, white matter. And as you see here, there is an enhancement of the leptomeninges or perivascular type of enhancement. So the difference between MOG, multiple sclerosis, and NMOSD is depicted in this picture. In case of MOG, there will be involvement of the anterior aspect of the optic nerve. NMOSD, there will be involvement of the optic chiasma, and multiple sclerosis, there will be unilateral involvement of the anterior aspect of the optic nerve. Spinal cord lesions here will involve the area postrema. There is the upper spinal cord, a cervicomeningeal junction. Conus will be involved in the MOGAD. Multiple sclerosis, short segment with whether the dorsal or lateral aspect. And this is a similar, these are the involvement of the brain images in the NMOSD, MOG, and multiple sclerosis. So the take home here is MOG can have varying stages of presentation. It can have ADM like picture. It can have MOG associated encephalitis. So whenever you are having a case of aseptic meningoencephalitis, you please you suspect MOG and we do a MOG antibody, and if it can be positive. This is the take home message here in this case. Coming to the last case is a case number 12. It's a 53-year-old male who is a known case of left frontal astrocytoma treated on 2012. And he developed recurrence, and surgery was done on December 12, 2025. And the patient presented with recurrent seizures on post-operative day 1. So this is a surgical area showing the craniotomy with subdural pneumocephalus, and there is hemorrhage within the operative bed. And we are able to see typical ribbon-like calcifications in the adjacent left frontal lobe, which are nothing but it is a case of oligodendroglioma, and there is a residue here. And after surgery, the patient developed recurrent seizures, and there is no subarachnoid hemorrhage in the supratentorial region. And as we go down, we are able to see some hemorrhages along the cerebellum bilaterally and in the cerebellar foliae. So this is the coronal and sagittal reformatory image showing the hemorrhages along the cerebellum. So we are getting hemorrhages far away from the operative site. It is called remote distant brain hemorrhage or remote cerebellar hemorrhage. Distant hemorrhage is a rare neurosurgical complication, most frequently in the cerebellum after supratentorial craniotomy. It is due to sudden loss of CSF, which leads to cerebellar sagging, compression of the bridging superior cerebellar veins, and hemorrhagic venous infarction. There will be laying of blood over superior cerebellar foliae, or rarely can be intraparenchymal hemorrhage. Similarly, another patient, this is a 53-year-old male patient who had recently had this surgery was done last week only. There is a large STH. The patient is a known case of left MCA territory, old left MCA territory. In fact, large STH with midline shift. And after surgery, immediate post-op, we are able to see multiple foci of petechial hemorrhages scattered all over the cerebral parenchyma, pons, and in the cerebellum here. So this is also remote cerebellar or remote distant brain hemorrhage. Coming to other surgical complications, this is a case of calcified meningioma with hemorrhage and air pocket in the operative bed. And after 5-6 days, this patient developed a pus in the operative site. That is in the sternomastoid, there is a pus here with showing an abscess with rim enhancement. And this patient has developed CVT. There is a venous sinus thrombosis. So these are all complications of a neurosurgery. And another patient with CP angle enhancing lesion with surgery related, and after that we are getting a pseudomeningocele. Pseudomeningocele is another complication of the neurosurgery, and rarely after surgery we may get global hypoxia. Global hypoxia, how to differentiate? is there will be white cerebellum sign on CT. The cerebellum will appear bright. Rest of the brain parenchyma will appear hypodense due to ischemia. And here there is a descending tentorial herniation with secondary midbrain hemorrhage. And another patient is a 75-year-old male who also underwent a craniotomy for surgical STH evacuation on the left side. Post STH evacuation, the neurological status deteriorated, and as you see, the MRI was done. And the MRI, we are able to see foci of restricted diffusion with T2 hyperintensity involving the basal ganglia, thalami. There are some areas of vasogenic and cytotoxic edema. And if you see the sagittal image, we are able to see the intracranial hypotension there. So it is a case of pseudo-hypoxic brain swelling, which is an acute neurological deterioration with features of hypoxic brain injury without clinical hypoxia. Here, without there is clinically there is no hypoxia, but imaging wise, the patient is having hypoxic like picture, and there will be acute deterioration. The pathology here is also due to sudden intracranial hypotension and venous congestion with basal ganglia and thalami restricted diffusion. There will be vasogenic and cytotoxic edema. Coming to herniations, in the post-surgery, the herniation of brain parenchyma through the calvary defect it is called extracranial herniation. And the same patient, after one year, has due to now they had done an ventricular drainage. There is a VP shunt here, and due to sudden loss in the intracranial pressure, the flap has sagged. This is sagging brain cranial flap, and due to this, there is a paradoxical herniation with a midline shift herniation and subfalcine herniation. Paradoxical hernia is a rare fatal complication of decompressive craniotomy, often triggered by acute imbalance of intracranial pressure, secondary to CSF drainage or lumbar puncture with consequent subfalcine and transtentorial herniation. Coming to the last case, which I have already discussed here, there is a appearance of infarct post-surgery. There is an ACOM aneurysm clipping, post-ACOM aneurysm clipping. There is an infarct in the recurrent artery of Hubner and in the orbitofrontal territory. So to summarize, we have seen 12 cases totally. The first 5 cases are a case of focal cerebral arteriopathy, and the importance, we have discussed the importance of vessel wall imaging and the newer vessel wall imaging technique here, mineralizing microangiopathy, the usefulness of CT and susceptibility to image in identifying the calcifications. And we have seen some rare infarcts like anterior choroidal artery infarct, which is often confused with an MCA or PC infarct, Petzeron and subcallosal artery infarct. And the next case, we have discussed a venous infarct and differentiation between a hemorrhagic transformation of an arterial infarct and venous infarct, and the importance of clinical history. The presence of seizures is more in favor of venous infarct. Hemorrhage in the early first 4 hours is more common in venous infarct. And then we have discussed the cases with spontaneous subdural hemorrhage bilaterally, and the importance in identifying the intracranial hypotension. And we have seen the rare variants of multiple sclerosis like BALO and Marburg, and the recent advances like central vein sign and paramagnetic rim lesions, which are included recently in the McDonald criteria in 2024, and the perfusion imaging in differentiating lymphoma, GBM, and metastasis. We have seen MOGAD and its patterns, particularly the take-home message here is aseptic meningoencephalitis, think of MOGAD. And we have seen some post-operative complications of cranial surgery like rare remote cerebellar hemorrhage. Thank you.
Thank you, sir, for your exhaustive lecture. You have given a very wide discussion about various diseases. It was very, very difficult to understand itself for the basic people. And how you were able to find out all these diagnoses is looks like a miracle, actually. So congratulations to all the winners of the total 11 questions. So it was a nice session, and it was an exhaustive session. I thank our 2 speakers of the day who were not at all leaving. Totally, each one of them have taken 1 hour each. Dr. Edmond sir and Dr. Arun both have exhaustively covered their topics exhaustively. Thank you for your nice session, and thank you for joining. Thank you one and all for joining. Participants are almost 120 participants were there. Thank you all the participants. Thank you, IMA AMS Coimbatore, for giving the opportunity to conduct the Neurosciences Forum. Thank you, one and all.